Namaste. IJV and Dr. Shaima Kadri from Faculty of Physiotherapy and Diagnostics. And today, the subject of surgery, we are going to talk about shock. So, what is shock? Shock is a condition in which the cardiovascular system fails to perfuse tissue adequately. Similarly, shock can be happen in the brain, CNS involvement. An impaired cardiac pump, circulatory system, and or volume can lead to compressed blood flow to tissue. Inadequate tissue perfusion can result in generalized cellular hypoxia, starvation, widespread impairment of cellular metabolism, tissue damage and organ failure, and then death. If we talk about the pathophysiology, then cells switch from aerobic to anaerobic metabolism. Lactic acid production, then cell function ceases and swells. Then membrane become more permeable. After that, electrolytes and fluids seep in and out of cell. Sodium and potassium pump impaired, and finally is mitochondrial damage and cell death. If we talk about the compensatory mechanism, the sympathetic nervous system, SNS, adrenal response. SNS is neurohormonal response stimulated by baroreceptors, which increase heart rate, increase contractility, vasoconstriction, and increase preload. If we talk about the compensatory mechanism as well as the SNS hormone, renin, antigenosine system, this is decreased renal perfusion, release renin, antagonosis second protein vasoconstriction, and release adolescent adrenal cortex, sodium and water retention. The antidiuretic hormones act as osmoreceptor in hypothalamus stimulated, ADH released by posterior pituitary gland, vasopressure effect to increase BP, act on renal tubules to retain water. If we talk about the response of the adrenal, then it's adrenal cortex, which responds as anterior pituitary release adrenoreceptive hormone, stimulate adrenal cortex to release glucose, blood sugar increase to meet increased metabolic needs. If there is the failure of the compensatory system, it may see as decreased blood flow to the tissue causes cellular hypoxia, anaerobic metabolism begins, cell swelling, mitochondrial disruption, and eventual cell death. If low perfusion state persists, there is irreversible and death immediately. The stages of shock are initial stage, compensatory stage, progressive stage, and irreversible or reflective stage. And lastly, death is immediate. If we talk about the initial stage, tissue are underperfused, decreased CO, increased anaerobic metabolism, lactic acid is building. In compensatory stage, reversible SNS activated by low CO attempting to compensate for the decreased tissue perfusion. In progressive stage, there is failing compensatory mechanism, profound vasoconstriction from the SNS, ischemia, lactic, and production is high, metabolic acidosis. Irreversible or refractory stage shows cellular necrosis and multiple organ dysfunction syndrome may occur that is immediate. Pathophysiology of systemic level is net result of cellular shock, systemic lactic acidosis, decreased myocardial contractility, decreased vascular tone, decreased blood pressure, preload and cardiac output. The shock syndrome have hypovolemic shock where blood volume problem occurs, cardiogenic shock, blood pump problem occurs, Destructive shock, where the septic, anaphylactic, neurogenic symptoms may seen, where the blood vessels problems occur. If we talk about first, hypovolemic shock. Hypovolemic shock resulting as the loss of the circulating volume, empty tank, decreased tissue perfusion, general shock response. The etiology is internal or external fluid loss, intracellular and extracellular compartments. Most common cause is hemorrhage and dehydration. If we talk about the external loss of fluid in hypovolemic shock, the fluid loss is dehydration, nausea and vomiting, diarrhea, massive diuresis, and intensive burn. If the cause is blood loss, then there is trauma, blunt and penetrating blood. Patient can see blood which is not visible. The internal fluid loss is loss of intravascular integrity, increased capillary membrane permeability, decreased colloidal osmotic pressure, which is third spacing. The pathophysiology of hypovolemic shock is decreased intravascular volume leads to decreased venous return, leads to decreased ventricular filling, leads to decreased stroke volume, leads to decreased COO, leads to inadequate tissue perfusion. The clinical representation of hypovolemic shock is tachycardia and tachypnea, weak, steady pulse, hypotension, skin cool and calming, mental status change, decreased urine output, which is dark in color and concentrated, assessment and management is depending on the severity of the fluid loss. 15%, that means 750 ml compensatory mechanism maintain CO. 15 to 30% refers to 7750 to 1500 ml hypoxia and decreased BP. 30 to 40% refers 1500 to 2000 ml impaired and profound shock along with severe acidosis. 40 to 45% refractory stage loss of volume is death. Classification of shock. So it can be classified as the blood, pulse, BP, output, and what is the treatment is given for. Therapy of hypovolemic shock, or we can say the treatment which is given for hypovolemic shock is airway, breathing, C-spine control, stop all obvious hemorrhage, insert IV lines, take blood from X-match, give rapid bolus of fluid, then assess response, decide to need for surgery versus decision to investigate. If we talk about the intravenous access, the rate of volume infusion is determined by the dimension of the vascular catheter, not by the size of the vein. Cumulation of the large central vein require catheters that are at least 5 inches in length, whereas cannulation of periphery veins may be accomplished with the catheter that are 2 inches in length. If we are doing the assessment for the intravenous, the central venous cannulation is reversed for monitoring cardiac filling, pressure and venous O2 saturation unless very large bore introducer catheter are used for volume reconstruction. Central venous catheters are 3 to 4 lines longer than peripheral venous catheters. The infusion rate through central catheters will be as much as 75% less than the infusion rate through peripheral catheter. There is talking the topic of the fluid composition where normal saline, lactate ringer. Now there is the another kind of shock which is cardiogenic shock. Syndrome of inadequate tissue perfusion associated with normal circulating body volume or blood volume and low cardiac output. Symptoms dyspnea, poor exercise tolerance, confusion, sweating. Sign is tachycardia, cold skin, high volume, added heart sounds, engorged liver, peripheral edema. The assessment is for the blunt trauma or to the chest, cardiac tamponade, cardiac dysarrhythmia, myocardial infarction, cardiac contusions, tachycardia, muffled heart sound, engorged neck veins and hypotension, dyspnea, edema in feet and ankle. The etiologies of cardiogenic shock are kind of two: mechanical, and there may be other causes. The mechanical complications are peripheral muscle rupture, ventricular aneurysm, ventricular septal rupture. The other causes include cardiomyopathies, tamponade, tension, pneumothorax, arrhythmias, and valve disease. The pathophysiology is impaired pumping ability to LV leads to decreased stroke volume leads to decreased CO leads to decreased BP leads to compensatory mechanism which may lead to decreased tissue perfusion. The cardiogenic shock pathophysiology may increase the impaired pumping ability of LV leads to inadequate systolic emptying leads to left ventricular filling pressure leads to left arterial pressure leads to pulmonary capillary pressure leads to pulmonary interstitial and intra-alveolar edema. The clinical presentation of cardiogenic shock is similar to catecholamine changes in the generalized shock and hypovolemic shock. May not typical tachycardic response if one beta blocker is heart is heart block in, or if bradycardia in response of nodal tissue ischemia. Mean arterial pressure below 70 mmHg comprises coronary perfusion. The abdomen heart sound is murmur, pathological S3, and pathologic S4 is atrial pericardial tamponade, muffled heart tones, elevated neck veins, tension pneumothorax, JVD tachycardial deviation, decrease or absent unilateral breath sound, and chest hyperresonance on affected site. Collaborative management involves goals of management, treat reversible causes, protect ischemic myocardium, improve tissue perfusion. Treatment is aim is early assessment and treatment, optimizing pump by increasing myocardial O2 delivery, maximizing CO, decreasing LV workload. The collaborative management is limiting, reducing myocardial damage during myocardial infarction, increase pumping action and decrease workload of the heart, inotropic agents, vasoactive drugs, intra-aortic balloon pump, transplantation. Consider thrombocytic angioplasty in specific cases. The management are optimizing pump function, pulmonary artery monitoring in a necessity, aggressive airway management, mechanical ventilation, fluid management, vasoactive agents, buprenorphine and dopamine, management optimize pump function, morphine as needed, continuous use of diuretics in CHF, vasodilators as needed for afterload reduction, short-acting beta blocker as monol or for refractory tachycardia. Goals, hemodynamic goals of cardiogenic shock are optimizing cardiac function involves cautions use of the combined fluid diuretics, introcept, vasopressor, and vasodilator to maintain adequate filling pressure, decrease afterload, increase contractility, optimize. The treatment is given for drug to move point back from down curve, example GT, and diuretics head up posture. Drugs to improve contractility, IV antidepressants, amiron, and ACE inhibitors. Drugs to prevent fluid retention, ACE inhibitors, diuretics. Other methods are IABP, VAD, heart transplant. Dopamine is a receptor activation at low doses. Beta receptor activation increase cardiac output. Alpha receptor activation vasoconstriction. Bubotamine primary a beta 1 receptor agonist, but is also has mild beta 2 effect vasodilatation. Causes a dose dependent increase in stroke volume, decrease in cardiac filling pressure, and alkaline pH inactivates catheteramine such as bubotamine. Dose is 2 to 20 msg per kg per minute. The non-receptance ferine is a delta receptor agonist and promotes widespread vasoconstriction. Disruptive shock is an inadequate perfusion of the tissue through the maldistribution of blood flow. Intravascular volume is maldistributed because of alternation in blood vessels. The etiology is septic shock, anaphylactic shock, and neurological shock. The anaphylactic shock is a type of the disruptive shock that results from the white space system. The pathology is antigen exposure, body stimulated to produce IgE antibodies specific to antigen, drug bites, contrast, blood crude, drug vaccines, re-exposure of to antigen, IgE binds to mast cells and basophils, anaphylactic response. Anaphylactic response may involve vasodilatation, increased vascular permeability, bronchoconstriction, increased mucus production, increased inflammatory mediators, and requirement to site of antigen interaction. The clinical representation of anaphylactic shock is almost immediate response to initiating antigen, cutaneous manifestation, erythema, pruritus, respiratory compromise, wheezing, bronchia, respiratory distress, circulatory collapse, tachycardia, vasodilatation, and hypotension. The treatment or the management is early recognition, treat aggressively, airway support, antihistamine, diphenhydramine 50 mg, forced corticosteroids, immediate withdrawal of antigen if possible, and prevention. The vasopressors to maintain organ perfusion, positive patent education. Neurogenic shock, a type of disruptive shock that results from the loss of or suspension of sympathetic tone causes massive vasodilation in the venous vasculature, return to the decrease venous return to the heart, decrease cardiac output. Most common etiology is spinal cord injury about T6. Neurogenic is the rarest form of the shock. Pathophysiology is disruption of sympathetic nervous system, loss of sympathetic tone, venous and arterial vasodilation, decreased venous return, decreased stroke volume,